Hello, everyone. Thank you for being here. So as Kristen mentioned, we have a great session ahead of us. So I will start with Dr. Mark Trial. I have one question for you. How does AI fit in the patient care pathway for breast cancer?
Thank you, Joanna, and also thanks to Blackford for this opportunity to share what I know about this technology. I've been using it clinically now for 5 years, so I've read thousands of images using the technology, and I will tell you sincerely and from firsthand experience, it definitely has made me a better radiologist. The patient benefits from a higher detection rate. I've had multiple examples where I've had small, subtle lesions across the board, and basically the algorithm presents them to me on a silver platter. So I can take them to tumor board, everybody goes, oh, you caught that, that's very good, and it was handed to me. So obviously detection is at the front of the line for the improvements, but it goes beyond that. It goes into triage, and that's something that's getting more and more important because a lot of places just don't have the manpower anymore. So the queue gets backed up, people don't get their screening studies read. You definitely have the ability to go in and look at your list and see what the scores are and prioritize the cases in terms of what's most suspicious and what isn't. So you can really pick up days or weeks in turnaround time for cancer patients if you choose to use this application. Two things it does very well: cancer detection, triage. Another thing that it does very well, which I want to share as a radiologist, I've been reading mammograms for 36 years, and I will say it does not get any easier. Sometimes you have 20,000 images come across the board, a little unhuman actually. This makes it so much easier. I've got a second reader next to me. My stress level at the end of the day is much better than it used to be, and my quality of life has improved. So it's a win-win-win. I'm a better radiologist, I do a better job, the patient benefits, and I'm benefiting. I do better, that makes me feel very good. I'm very happy to be able to say that my performance at this point in my career is the best it's ever been. And that would not be the case if it weren't for the AI technology that I've been relying on very heavily for the past 5 years. So hats off to iCAD and all the vendors who put this technology out there. I can't wait to see this become universal. I think eventually you're going to find that this is in use everywhere. I think it's only getting started. So
Thank you so much, Dr. Mark. Eric, thank you for joining us. So I have two questions for you today. What are some of the challenges in monitoring patients and treating patients with metastatic cancer? And if you can also answer, what are the benefits of identifying poor treatment response earlier in patients?
Absolutely. And so, first of all, thank you to Blackford for giving us an opportunity to talk as well. And so you can tell from the question that we're addressing a different part of the patient journey than the last answer. We're focused on patients with metastatic disease, diagnosed already with metastatic disease, and looking at treatment response. Among patients that have 5 or more lesions, 4 out of 5 of those patients will have heterogeneous disease that leads to heterogeneous response. It is impractical in most cases to manually measure across multiple images, match, and do a quantification of how every single one of those lesions is responding to therapy. And yet, less than 10% of disease not responding will drive a poor overall clinical outcome. If you can quantify how every single lesion is changing, you can catch that resistance as it's forming. And in many cases, you can use something like targeted ablation to go in and treat trace amounts of disease resistance before it clones and spreads and then drives a poor outcome for the patient. And so that's one way that we're seeing it across all cancers, but including breast cancer, the ability to better manage these patients with advanced metastatic disease, keep them stable on a less aggressive treatment, less toxicity for longer, and ultimately leads to better quality of life.
Thank you. Very interesting. What about Dr. Ambika? Please tell us about how would you reassure clinicians burned by traditional mammocats that mammo AI is different?
Yeah, thanks for the question and thanks to Blackford. Also, thank you to the audience for being patient and hearing us out. So traditional CAD did actually leave a pretty bad taste in the mouth for most of the radiologists. Especially, we had customers in Australia who had to tell us that please replace the button, the name on the button that shows the CAD output, because they didn't want the CAD word there. They wanted it to be replaced by AI or something else. And the problem with traditional CAD was the extremely high false positive rate, Most of the times, radiologists spent a lot of effort reassuring themselves that the traditional CAD was wrong rather than relying on the results. Now, when we look at the problem per se, it's more of a problem in terms of association and experience because radiologists have been trained in a particular way. And when we look at training for traditional CAD, it was trained with the image patterns that the humans could see. So it was just like the humans would pull out patterns, let's say speculations, lobulations, pleomorphic microcalcifications that point to cancer, and they would feed it into the traditional CAD model. The difference is that humans have more intuition, they have clinical information, they have priors, so they can make informed decisions whether to recall or not. But the CAD learned what it was fed. So there was no way for it to know whether it was a true positive or a false positive. Now, when we talk about the deep learning AI algorithm, there are some basic fundamental differences between deep learning algorithms and traditional CAD. So let's start with the model. In terms of the model, the traditional CAD had a very simple classification model, but deep learning has a very complex neural structure. There are multiple layers with different nodes. They sort of crosstalk with each other. That's the first point. The second point is that when we train the deep learning algorithm, we are not putting in features that are handcrafted by humans. We train the deep learning algorithm by using the ground truth, and the algorithm learns on its own what are the image patterns and features that are associated with cancer. So there is no restriction to the number of features the deep learning algorithm can learn. And also, it learns live. So with more images that the algorithm is fed, it's going to look at more patterns, even for the subtle cancers like subtle asymmetries, distortions. The more images that we add into the model, the better the performance of the model is. Also, not just the model, but we need to look at the data quality and the images per se. So when we look at Lunit, we have trained a model with more than 3.3 million images as of now. And thanks to our association with Volpara, we have a treasure trove of more than 100 million images that we are going to be using pretty soon. Also, the quality of the training data is very important, not just the quantity. We are very aware that dense breasts are particularly challenging. And that's why more than 70% of our training data set is dense breast. We also include data from different countries just to make sure that the model is generalizing well. So when we take all these things into consideration, we get two things. One is early detection of cancer, and the other is reduced false positives. And these were the problems to begin with in the traditional CAD. So with the deep learning model, we do not have these problems, and this is something that I would explain to the customer as well.
Thank you so much for your comprehensive response. What about Mo? Please tell us, how can AI help improve mammography imaging quality and why it is critical?
Thank you, Blackford, for the introduction, for having us, and for allowing me to speak about image quality. Fundamentally, garbage in, garbage out. The reality is everything starts with quality. Whether it's a radiologist or a CAD system, they all rely on good quality images. Moreover, it's not just a clinically important factor, but it's also a regulatory requirement, certainly in Canada and the United States, elsewhere, where image quality is monitored very carefully. Mammography quality is monitored very carefully. In the United States, it's the FDA MQSA, EQUIP, and in Canada, we also have a different program, the CAR MAP, and they monitor quality at the facilities, and they establish criteria for accreditation, and that covers a whole bunch of different positioning errors, but all of it is driven by the requirement for ensuring that the images are good quality. So most AI is transactional. You have an image, you get an AI result, you move on to the next image, you get an AI result. What we've done is bring together or continue to establish a database as the images are processed, every mammogram matters. So every mammogram is processed, the results are stored, we're able to evaluate trends over time, we're able to indicate where there are differences between one facility versus another. It's not fair to evaluate a technologist or a radiographer just based on one image. You need to see the profile over time, whether they're consistent over that period. And so we're able to provide these objective assessments of quality so that the lead technologist, the institution can provide some feedback to the technologists and the radiographers so that they can improve their positioning. But certainly, the biggest aspect of this is that collecting data over time allows you to evaluate in a rigorous fashion in a similar way to the American College of Radiology Learning Network framework, where the Empower program, where they established a framework for evaluating quality. And so we've aligned our AI-driven tools for quality very similarly to the framework that the ACR has established. And I'm excited that we're collaborating with them to make sure that we continue to be aligned with their framework.
Thank you very much, Bowie. Thank you all for joining us today. Are there any questions from the audience? So please, there is one question.
Hi, how you doing? Thanks for letting me ask you this question. With the detection world being very important to find cancer early and such, could you give me a sense for the AI detection, the comfort that your customers will have to be confident nothing is there based on the AI? Based that nothing is there based on the AI. Detection is important, but almost every case is non-cancer. So how does that work?
Correct. So the confidence levels for the algorithm are the highest at the bottom end of the scale. 1 in 4,000, something like that, if it's 20 or less in the algorithm that I work with. So it approaches autonomy at that level. And that's also where you're going to see the vast majority of your scores. So it's kind of the heavy lifting part of your day, identifying what's negative and passing it along. You're making a binary decision when you look at a screening mammogram. You let them go or bring them back. If you have a low score, that's high confidence from the algorithm that there's nothing there. And so basically what you can do, I'm not advocating you don't look at them. I'm not advocating autonomy, but you can speed through those. You can basket those, maybe send them to the person that's not as skilled with mammography. Maybe you got people reading that aren't fellows. They could take that bucket of films and knock off quite a few RVUs, knowing ahead of time that they're probably not going to be seeing anything. So a lot of the discussion has always been about cancer detection. How can we find these cancers? And I've missed cancers. It's a terrible experience for me and the patient. So AI has definitely done a fantastic job with that, but even more so, I think, and more confidently, it's very, very good at telling you what's negative, and that is also very, very helpful.
Thanks, Mark. So in a typical screening population, about 80 to 85% of the cases would not be flagged as suspicious by the AI. So that means you're not getting those many cases to look at. Also, not just in terms of sensitivity, when we talk about specificity, the specificities are pretty high. And we have seen there are cases where the radiologist picked up false positives and the AI did not. So it's not just good sensitivity, but also a good specificity that we bring to the table.
Thank you all very much.